Can we start? Okay. So good afternoon, everyone. Thank you for joining this special session sponsored by GE Healthcare. As you know, this valve meeting obviously deals with structural heart disease intervention, and the role of imaging is getting even bigger and bigger when the complexity of the procedure is now not only from the aortic, but also to the mitral and tricuspid space. And as you know, the fundamentals of basic imaging of choice would be transesophageal echo, but in some circumstances, it does not provide the best or the optimal imaging quality. So we need some additional tools to overcome this kind of circumstances. And today we will deal with those situations, and we will talk a little bit about Mini 4D transesophageal echo probe and 4D ICE in terms of trying to optimize the patient outcome with this complex scenario. So today we are fortunate to have three special speakers, imaging experts, and I'm interventional cardiologist at Tokai University Hospital, Yohei Ono. Although I'm an interventionalist, I love imaging. So I'm very happy to join this session by myself and very much eager to learn a lot of things. So without delay, I would like to introduce our first speaker, my great friend Si Hoi, who will give us a talk about clinical benefits of the Mini 4D TEE probe in TAVR procedures. When you're ready.
Thank you, Yohei. And thank you very much for your very nice introductions. I know you love imaging. We've seen how you've done all the CTs and pre-planning for TAVR. And I must thank GE for giving me the opportunity to share some of my experience using Mini TEE probe in TAVR procedures. This is my disclosure. Well, as you know, TAVR has been done really very nicely since 2010, when the first trial of randomized trials in the high-risk and inoperable group in 2010. But so far, a lot of us actually has done it without the need for general anesthesia. And the general anesthesia was what we did in the past. But if you looked at the last probably 10 years almost, a lot of hospitals are doing it conscious sedation, including my hospitals, 100%. There is still conversion, if you look at the TTT data, that about 6% will convert to general anesthesia because of vascular complications as well as hemodynamic instability, that you need to support the patients with intubations or an ECMO. Here I have a patient. Here I'm going to discuss about intra-procedural imaging in TAVR in particular. We're used to standard transesophageal GA mode where we continuously monitor. Right now, most of the time, I'm like this, ducked in next to the interventionalist once they have done with the procedure to do a transthoracic imaging. And especially worse if the patient became hypotensive and they go, imager please. And then you got to really duck under and get a transthoracic quite quickly. It's not easy, by the way. So what happens if you look at the data coming from Gilbert Tang's group, that patients who had transthoracic imaging immediately post-TAVR versus pre-procedure, like a few days before they get discharged, that is actually increased in terms of PVL, at least about 5% of them. Comparing on table and before discharge. And most of these is missed actually in about 31% of the 13 patients, about 31% have moderate PVL, which you would have to optimize if you can before the patient leave the theaters. What are missed are actually the posterior jets on the transthoracic that tend to be missed because we scan transthoracic anteriorly. So just bear in mind that we know PVL, anything more than mild is related to not so good outcome for post-TAVR. Now, real imaging or real-time imaging is helpful if you are in a less experienced center. Say if you are starting the TAVR early on, so you really want to know what's the outcome. TAVR procedure still is high cost even in a lot of countries such as in Asia or Southeast Asia. So we tend to want to make sure that our patients get the best good results and don't come back again if it's possible. And the high-risk anatomy are those we don't have all the straightforward anatomies. You can have patients with low coronary heights, risk of coronary occlusions, or those with septal hypertrophy when there may be a risk of embolizations, as well as those patients with small LV or patients with bicuspid severe aortic valve calcifications that may increase the risk of PVL. And patients who has bad LV functions also are the ones that may go into problems after you balloon the valve or before even you put in patients just under conscious sedations. So I think anticipation such cases will be helpful if you can get something in the imaging side that is continuous but without the need of general anesthesia. We did that in the past using micro TE, mini, really small, and about 6 to 7 millimeter. It allows you to get continuous monitoring without the need of sedation, general anesthesia, but the image are actually not as easy. Sometimes you need to hold the probe and it's very long. Currently, what I have here, I was told, is this mini TE is the size of about 11 millimeter width. And as you can see, it's really quite tiny. A lot of patients can do this without the need of general anesthesia. You put it in, patient just have to have a little local anesthesia at the back, and they can swallow. And remember, most of our TAVR patients are elderly, and they are quite insensitive when it comes to the oropharynx. And what is good about this mini TEE is that it allows you to do multiple things, 3-dimensional imaging, as well as full volume or cropping using the MPRs. So in our cases, for the last, I think, 3-4 years now, we have been doing conscious sedation in all our TAVR cases in Singapore. That's where I come from. And we did this for all cases, floating a mini TE after the patient's on table, explain to the patients, and they just swallow quite easily. Anesthetists love it because they have no issues, and then we have a cardiologist here that looks at the patients. So what do we use? We use when we have a patient who has got kidney disease and may not have done a proper CT, or a patient who has poor quality CT that annular dilatation needs confirmations. So we can do that on our mini TE, doing MPRs, and then get an estimate, in fact, quite a true estimate of what the annular size. What else? With the 3-dimensional capabilities, these images are done on mini TE on our patients. You can also measure the height of the coronary. In fact, the beauty of this system is that it has got these 4D markers that you can label. In this case, the yellow is the left main, and the RCA is a red dot. And then you can then use the vertical height to measure the true coronary ostium height from the annulus. Sometimes this is really helpful in a patient with bicuspid where crossing of the aortic valve can be a challenge. And this is when I was telling my interventionist, there you go, you know where your wire is. You can do your own adjustment, and they can actually then avoid the calcified cusp and go to where the flow is, which is facilitating the crossing of the aortic valve. And then also, what we are worried about when it comes to post-aortic valve ballooning is the risk of aortic regurgitations. And then immediately here you can see that though it was a calcified valve, in fact, the calcium is actually split open, as you can see here. But we didn't do an embolic prevention for all our patients because there's a reimbursement issues, but you can see that this has got risk of, obviously, stroke. So all these can be assessed constantly during the procedure. And of course, we then can check very nicely the need for whether to do reballooning or not. Sometimes we have very poor LV patients. This is a case of the LV about 15 to 20% with severe aortic stenosis. And you can see a great echo contrast just in the LA as well as appendage. We can assess whether there's any presence of clot. And at the same time, even before, just as we crossed the aortic valve, the patients went into PA with hypotension. And then the first thing they did was, of course, doing CPR. And the next thing they asked me to do is, Dr. Yu, is there any problems with the RV pericardial effusions or dissections? So I quickly check. And then I could be very certain that it was just the flow, that it was low with no dissections and no pericardial effusions. And we started CPR. In fact, we quickly put in the valve, and the anesthetist could easily just intubate the patient without the need to remove this from the throat. So you can see that it really doesn't impede on the anesthetist's way of managing the patients because it's a very tiny probe. And the patients recover very well. So the next thing I think really helpful is that not only we can assess the balloon effect after ballooning, but we can also determine if there is any severity of paravalvular leak. In this case, there were paravalvular leak in the center patients, and then after ballooning, the paravalvular leak has almost diminished. So the decision to re-balloon or not on live TEE guidance, including your fluoroscopy and hemodynamics, it really helped you whether it's safe to do so and whether there's a need to do so. Lastly, without the TEE probe, sometimes you don't really know what's the cause of hypotension. In this case, this is an entanglement of the mitral valve subvalvular apparatus with mitral regurgitations, and there was a drop in hemodynamics and donor blood pressures. And once we had a look at it, we adjusted the wires, and the MR immediately improved. When you have patients with hypotension, TE quickly assess, for example, the need of whether there's any tricuspid regurgitations or IV dilatation. Sometimes they happen. Or there is any pericardial effusions or dissection. So ladies and gentlemen, I think with the minor probe like this, or mini probe like this, we could easily do a procedure such as TAVR in a conscious sedation patient without the need for GA, and yet you get lots of information doing this together with a straightforward TAVI cases. Thank you so much for your attention.
Thank you, Sioi, for really a comprehensive and excellent talk. I would like to ask audience, who is interventionalist or the surgeons? インターベンションか外科の先生いらっしゃいますか？ありがとうございます。Who is imaging physician or the sonographer? イメージングの先生もいらっしゃいますね。Okay, who is nurse? Other clinical specialists? Okay, so I would like to ask you a couple of questions, if the time allows. So, the images you've shared is really optimal, but I had an experience using this mini probe. Obviously, it's really less invasive, without doubt. But since the probe is so small, the attachment to the esophagus sometimes could cause suboptimal image. So, do you find this any obstacles, difficulties?
Yeah. Thanks, Yohei. I think when we first started, it was difficult because the contact with a mini TE in your throat can make the image not so good, especially appendage. Actually, I find the appendage really difficult to see. But Mata will show us later how.
Exactly.
Yeah. What I do is actually we kind of hold in place and do retroflexion, and that helps a lot because you're just keeping the probe in these directions. And that's constant posture or constant positions. And the key is actually contact with the esophagus such that the imaging is straight on. I don't have any issues actually optimizing the image because I realized that I learned the trick. I use the flexion and then it holds. And most of my patients at the end of the procedure actually says, "You done?" I said, "Yeah, I'm done." So they don't really feel it. Now, during the procedure of TAVI imaging, I actually leave it on the holder. I don't hold the probe. I only hold the probe when I need to take the pictures. So to me, it's an additional thing, and my hands is free. Rather than the small little micro TE, which is too short and too tiny, it flip out. So I don't like them because it's heavy at the handle, and the whole mini TE probe will float out, and I have to constantly hold it. Not for these cases with the mini.
All right, very promising. So the last question to you is, you perform all of these procedures under conscious sedation. So I understand that with your expert hands with the Singapore Heart, your center, the procedure time is quite short. So is there any chance of, like, say, like aspiration or those kind of problems, issues?
Actually, no, because we do 4, sometimes 5 cases of TAVI in a day. And because this is conscious sedations, we are very certain that the cause of hypotension or complications were very easily detectable. In fact, they ask for it. The surgeons or the procedure will tell me, please be around. I say, be around and do what? Please do the TE.
Exactly. これプローブがちっちゃいので時々食道との接着が悪くてイメージがうまくいかないことがあるんですけど、先端を少し曲げることでだいたい回避できますよってことと、あとは全麻じゃない状況で使うのでちょっと誤嚥とかがどうかなっていうのを質問しましたけど、それも短い手技時間で問題ないでしょうということでした。So thank you so much for a great talk. So next I would like to invite another distinguished imager, Marta from Barcelona. Welcome. You're the very first visit to Japan this time, right?
Yes. So thank you. Thank you for the invitation, and thank you for General Electric for supporting me. So I will talk a little bit on our experience on using this small probe that you have already seen precisely in left appendage occlusion. So these are my conflicts. So as said previously by the chairman, an ideal intervention should have minimal access, no general anesthesia just to avoid risk, but patients should be comfortable. And this ideal intervention should have the same safety and outcomes than a conventional intervention. And ideally, it should be performed on an ambulatory basis. Why? Because we avoid risk of being hospitalized for the patient. In this sense, the development of imaging and being able to see the tip of the catheters has been an essential tool and crucial to perform all these transcatheter interventions, together with the technological development of the transcatheter technologies. As said before, we have currently the conventional transesophageal probe with all 4D capabilities. And we used to have the micro-TE probe, which didn't have 3D capabilities, only 2D capabilities. But now we have this 9VT probe, which is the mini TE probe, which has exactly the same capabilities of a conventional 3D probe. Of course, the size is smaller, as shown. You can see the hand of a physician with the 3 probes. The size is smaller, and sometimes you have problems with the contact, as previously mentioned. So the first thing when we got this probe, we wanted to explore how was image quality, targeting in this case for LA left atrial appendage occlusion procedures. Why? Because these are very simple procedures, 20 minutes procedure. So we wanted to see how was the image quality. And as you can see here, you can compare same patient, different day, but same patient with the conventional probe on the right of the screen, and with the mini TE probe on the left. And as you can see the left appendage. You can see you can rule out thrombus inside. And these are different patients. As you can see, the image quality, you can see that somewhere here, maybe the contact sometimes is a little bit more difficult, but really, I mean, I was impressed by the comments previously, because most of the patients, we don't have any trouble in imaging the appendage. And as you can see, the image is of high quality and very similar to what we get with the conventional probe. Also, MPR capabilities, so we can do the sizing. This is exactly the same patient, same size of the landing zone for sizing the device for occluding the appendage. And this was our first experience. This was a male with a weight of 55 kilograms. Duration of the intervention, that was our very first case of left atrial appendage occlusion using conscious sedation with this mini TE probe Fluoroscopy time was 10 minutes, and the duration of the probe insertion was roughly 20 minutes. So after this initial experience, we said, okay, typically, as you know, we use imaging for planning LA closure procedures because we want to look the anatomy, we want to see the complexity, the morphology, and the strategy to occlude the appendage. We want to rule out thrombus, and also we need the sizing. So typically, we use 3D imaging methodology, either CT or 3D TE with a conventional 3D TE probe. And while guiding the procedure, we have different options. So we have the conventional probe, the big one, let's say, but of course that's uncomfortable for the patient, and we use general anesthesia and mechanical ventilation during the procedure. We can use 4D eyes for those who have it available, but we have an issue with the cost because this is costly, and also for the environment is not that good. Also, we can use the micro TE, but then we don't have 3D. So that means that definitely we need to use something beforehand to do the sizing. And finally, now we have this mini TE probe with these 3D capabilities. And this is what we wanted to study. So we performed a registry in the first 63 patients that we did. We have more now, but this is the first series that we published. Mean age was 77-year-old, 60% were male, according to the normal epidemiology. And weight, and this is important, mean weight was 73 kilos. So these are normal Caucasian patients. We use this protocol for conscious sedation, midazolam, mean 1 milligram, and fentanyl between 25 and 50 micrograms, plus topical pharyngeal lidocaine. And there was no anesthesiologist in the room. We were performing all the job. Our feasibility with these patients was 98%. Only one patient was not able to be intubated, and of course, there is a learning curve, but some patients just don't tolerate, but it's a really, really few proportion. We did these procedures using different devices, and Platzer is the one that we use more, but also others. Mean procedural time was 47 minutes, mean X-ray exposure time 8 minutes, no complications, and in more than 80% of the patients, we did this on an ambulatory basis, so same day discharge from the hospital. So we proved that this procedure was safe. And also, in the first 40 patients, we performed previously sizing with a conventional 3D TE probe, and we found no significant differences in the measurement of the landing zone. So we proved this was also precise. So currently, our protocol, indeed, is mainly using the 9BT, the micro TE probe with these 4D capabilities, and we have avoided all the pre-planning studies, so avoiding CT and previous transesophageal echocardiography. So, as you know, these patients are all anticoagulated, so we go directly to the cath lab, we check there for thrombus, we do the sizing, and we just do the procedure. Everything under conscious sedation and minimal anesthesia, and in most of the cases on ambulatory basis. Given that initial experience, we wanted to go further, and we have started another protocol with a kind of a point of care follow-up protocol for after left atrial appendage occlusions. If you all work in an echo lab, you know we have many of these patients filling up the agenda of the transesophageal echoes for follow-up, because we need to make sure that there is no thrombus on the device 3 months after, 1 year after. So we have a bunch of these patients. So we have started using this mini TE probe for a point of care transesophageal echo, so very directed only to look at the device, to look if it is well seated, if there are thrombus on its surface, and if there are any leaks. Up to now, we have been performing this in 4 patients, only with topical lidocaine, and it's perfectly well tolerated. It's 20 minutes between the patient comes into the door and he or she goes out. And this is the type of image that we get. As you can see, we can see perfectly the surface without any thrombus, and it's sensitive enough to even detect small leaks as the one shown here. So to sum up, a Mini 4DT Pro provides excellent image quality for assessing the left atrial appendage and for guiding left atrial appendage closure procedures. This smaller size of this Pro with all the capabilities allow for well-tolerated and safe procedures with conscious sedation, avoiding the need for anesthesiology, endotracheal intubation and mechanical ventilation, and hospital overnight stay. And our initial experience with a point-of-care protocol for follow-up transesophageal echo after LAA occlusion seems also promising. Thank you very much for your attention.
Thank you, Marta, for the great talk, and congratulations of the minimalist approach. It looks really promising. Is there any questions or comments, feedback from the audience? So I have one question. So obviously we started from the screening based on the TEE screening and then shifted towards CT-based screening. And now you even do not do any kind of screening and directly to the cath lab with this nice 3D mini TEE. So of course anticoagulated, so less chance of thrombus. But is there any sizing issue that you had to decline the procedure, like too large appendage or?
I think in all our history, I mean, we have very experienced interventionalists in closing the appendage. I think in our story we have more than 400 procedures, and there was one case they could not close. So sizing is usually now, I mean, we did this series comparing previous and previous planning and on the day of the procedure, and there was no difference. So now we go directly to the cath lab. It's important that we take our time to fill in the left atrium. I mean, a minimum and a pressure of 12, okay? So that's important. Not to have a patient very shrink, because sometimes then the size might change. But if you do this systematically and in the right way, we had no issues with that.
Great.
And the other thing is that we have availability on shelf of all the devices.
Right.
That's an important point.
3 types of devices,
3,
various
4,
kind of sizing. And
so we have all the sizes there, because if you have to be in advance, choose the device, I mean, you cannot do this.
Sure.
We have them on the shelf, so we can choose, and we decide on the moment.
Great. So I know you don't have full access to the 4D ICE at this moment. If it is available, will that change your practice? I mean, you stick to this 3D mini probe TE-based approach, or potentially?
I mean, for left appendage closure, for ASD procedures, I mean, PFO or ASD, I mean, this is our routine practice, and it's not going to be changing because in terms of cost, also of environment and the tolerance, it's safe, it's precise, so why should we change? I don't think in this point 4D ICE offers any advantage, but we will listen to Dr. Ho. The tricuspid is another story, because we have tried the probe. We haven't tried for TAVR because we are doing transthoracic, but maybe we try after hearing you. We have tried for mitral procedures, for mitral clip, and it works quite well also. And we have tried for tricuspid, but still image is not that good. So I think their ICE might be an advantage. But unfortunately, we don't have it available yet. Soon.
Thank you so much, Marta. 左心耳閉鎖におけるこのミニ 3D T プローブのちょっとお話をしていただきましたけども、最初我々も左心耳閉鎖の前はいわゆる普通の 3D の T で、スクリーニングしてオペ行けるかどうかを決めて、今は CT だけをやってオペに行くっていう多分施設も増えていて、でも今伺うとそれすらやらずにもうダイレクトにカテ室行って、工業庫してるんで血栓はまずないだろうっていうところで、もうその場でこの細いプローブ使っていろんな何種類かあるデバイスサイズから適切なのを選ぶっていうかなり進んだ取り込みを紹介いただきました。So I would like to invite Edwin. He's supposed to be here, but unfortunately he's not here. So let me open his file. Okay, this should be okay.
Hi, Hi, everyone in Tokyo. Thanks so much for inviting me to be a part of this session. I'm so sorry I couldn't be there in person to join you this year, but I promise to join next year. I do want to spend the next 8 minutes sharing with you some learnings and experience over the last couple of years of using 3D ICE for tricuspid procedures and mention a little bit about mini TE as well. Before we get started, these are my potential conflicts to report. And then over the next 8 minutes, first I'll discuss very briefly some of the clinical and imaging challenges that we face in tricuspid interventions. I'll talk a little bit about ICE workflows, to 3D ICE versus 2D ICE, how it specifically applies in tricuspid interventions with some case images as examples, and then briefly mention at the end a little bit about the potential mini 3D TE as well, hopefully to launch some good discussion with the panel there. So as you all know, tricuspid interventions are actually increasing in frequency, and they represent really great therapy options for our patients who are at high risk for conventional open heart surgery. With that said, these technologies are not perfect, and we do know that there are some risks and complications. So for example, in the data from TTIR, we know that there is some degree of single leaflet device attachment, and that may be because of inadequate visualization or insertion during the procedure. Bleeding is often a significant risk for replacement and repair technologies. And so we really want to do as much as we can to minimize the risks of these procedures, especially at the time of the procedure when we're doing the TE and the actual duration of the procedure itself. We know that while TE works very well in some cases for tricuspid interventions, sometimes it can also be extremely challenging. So here are some examples where there may be significant shadowing from prosthetic valves. A lot of times the position of the esophagus makes the heart appear very horizontal and introduces a lot of lateral shadowing from delivery systems. And then we also know that when we're really trying to optimize TE imaging during these types of cases, we can actually cause some harm. So there's 2 studies that did report in a large number of people, whether you look endoscopically or just from the clinical outcomes of these patients, there are certainly some complications associated with the intraprocedural TE, especially when it comes to bleeding. And these studies were actually looking predominantly at mitral interventions, and we all know that tricuspid ones take even longer and sometimes require more probe manipulation to optimize the image. And that's where ICE comes into play, because there are some advantages compared to TE. In particular, there's a direct line of sight with the tricuspid valve. It brings the valve more in the near field as opposed to far field imaging, and it's really independent of the esophageal position relative to the chambers of the heart and other structures that may introduce shadowing to the tricuspid valve. This is our typical tricuspid TE ICE workflow at Montefiore. So I stay at the head of the bed at the echo console. That way I can control the TE probe and do all the 3D manipulation that's so important for 3D ICE. The implanters often will actually park the ICE probe in a stable position, and then most of the manipulation is then done digitally, and we can switch back and forth between the 2 modalities. And I'll show you some case examples of what this looks like in real life. When we think about 3D ICE versus 2D ICE, of course, the physical manipulation of the probe and the catheter itself remain on the 3D actual ICE catheter, but what's powerful about it is that you have a matrix array, and so you can actually manipulate your imaging plane just like with 3D TE. You can adjust your omniplane angle, you can do biplane, you can do live 3D, as I'll show you in the next couple of slides as well. When we think about sort of the 3D ICE specification, so the New Vision catheter does have a matrix array. The crystal arrangement's a little bit more rectangular than your typical adult or pediatric 3D TE probe, but it still gives you actually a very large 3D volume size and allows for live manipulation, for example, with MPR. This is what the setup looks like, so you can use an E95 or an S70. This is the actual ICE probe itself. It can actually flex in sort of one axis, 120 degrees one way, 30 degrees the other way. And what's very unique about this catheter is that the tip can actually rotate independently of the catheter by 360 degrees. So it gives you another degree of flexibility when you're actually trying to find the optimal position for the catheter during a case. Just as a quick example of what some of the baseline images can look like with this catheter. So here's an example of a tricuspid inflow-outflow view, just like we would do with TEE, and then a biplane that can be swept across from anterior to posterior to look at the orthogonal planes, and what you might use as your grasping view for tricuspid edge-to-edge repair. What's powerful about the software on the E95 and S70 is that there's also biplane prepare, so you're not really guessing the angles that you need to use for these types of two-dimensional views. You can actually build them off of a live 3D data set. You can also do, of course, live 3D and live 3D MPR. There's a number of layouts you can choose from. You can use 40 markers like that's demonstrated here. What I really like is this dual short axis layout because you can set one axis plane to the level of the leaflets and another one to the annulus or device if you're trying to visualize that a little bit more clearly. In terms of actual procedural case examples, I did want to show you a few here. So this first one is a tricuspid valve-in-valve procedure. So it's a patient with a tricuspid prosthetic stenosis that was treated with a valve-in-valve using 3D ICE only. This allowed us to actually do this procedure with minimal sedation and actually kept the procedure very, very short while allowing for really, really good echocardiographic monitoring throughout the procedure and really good communication between the echocardiographer and the interventional cardiologist performing the procedure with these markers and with using special rendering tools such as the one that you see here so that we can really understand whether or not there are any problems with seal or paravalvular leaks, or are we just seeing rendering shadows that are not actually defects in the actual valve or surrounding valve structures. More commonly, of course, we talk about tricuspid tear when we think about tricuspid procedures. So here are some in-case examples of an edge-to-edge repair. So this is our first device, a little bit more anteriorly, and you can see how good the leaflet visualization is, even at this 90 degree, which is a little bit worse than the 0 degree because of the rectangular nature of the array, but really, really very clear for leaflet insertion and when you're doing your grasping. Here's a second device being placed on the same patient. So again, you can just really see very clearly that those leaflets are in both of your arms before you're lowering your grippers to actually grasp the leaflets and close the device. And here's with the second device closed. I don't have all of the rest of the ICE images just in the interest of time, but this patient had a very fast procedure with an excellent result. It was really assisted by using 3D ICE. I did show earlier that MPR can be very useful. It really is extremely good quality in many situations when you can position the probe close enough to the valve. Here you can see we've actually generated essentially the same views that you're used to with TE, an inflow-outflow, a grasp view, and again those short axis views that really give you orientation of the device relative to the leaflets. And as you can see here, even using live 3D MPR, it's really so clear that in many situations you can do leaflet grasping without even going back into biplane or 2D imaging. And so as you can see, hopefully from this example and this workflow that I described, the combination of using TEE, and I usually park the probe in the transgastric position, and using ICE 3D as well as ICE 2D imaging can be such a powerful and efficient combination that really gets us through our tricuspid tear procedures in a very quick way and results in very good procedural outcomes. I have one quick example of just its use in TTVR as well. So many of you will recognize that this is an evoked device with its anchors, and here we're evaluating for leaflet insertion. Just like with 3D TE, we're able to see all of our planes, and we can do the same spins that we usually do to check leaflet insertion within each one of the anchors. And again, the dual short axis view in this situation, I think is really helpful because you can really keep your eye on the actual anchors themselves in one view, but then actually optimize the plane to try to see some leaflet motion in another short axis plane. There are, of course, some limitations with 3D ICE. It's not a perfect technology, at least not now. There are still some physical limitations of the matrix array size. So the image quality is excellent, as you've seen in these examples here, but it does take a little bit of a hit when you compare it to the adult size 3D TE probes. There's also a smaller field of view, so initial device steering is not as easy to visualize in the right atrium, and that's why oftentimes we'll still combine this with TEE, and there's a bit of a learning curve, but rest assured, it's actually a learning curve that everyone can overcome, and there's excellent training options that are available to get you more used to it. The elephant in the room, which is a saying that we use in North America, just to say that this is something that can't be avoided, of course, is discussions about cost and a little bit of access, just because I know that the launches have been staggered throughout the world, but I think more and more different countries and regions are actually getting access to these technologies. Very quickly, I just wanted to mention 3D Mini TE because I think this is also an important part of our toolbox when it comes to tricuspid imaging. So on the GE platform, we have this 9VT probe now. It's quite a bit smaller than the adult 3D 6VT probe, but there's almost the same number of elements and it gives you almost the same field of view. So it's really quite an amazing tool. And the big questions are, what can we do with this, especially in the tricuspid space? This is a transgastric view from a screening TE that I did with a 9VT. I don't have case examples in the interest of time, just from actual case done with this, but hopefully, there'll be some discussion on the panel. But the big question is, can we then do these procedures with a little bit less sedation? Is there a lower risk of esophageal or GI injury? And then especially as the image quality continues to improve with hardware and software improvements, this really may have a huge role in how we do tricuspid imaging in the future. So in summary, while the current TE workflow is generally very good for most of our tricuspid cases, there's definitely room for optimization. And of course, we all encounter those difficult cases. Hopefully, I've been able to demonstrate that 3D ICE is really a very powerful tool. And those 3D features that are very similar to TE are what really make it so functional. Mini TE, I think there's a lot of options for it moving forward. And hopefully, you'll have a good discussion about what some of the worldwide experience with that has been. Thank you so much for your time. And again, I hope to see you all soon.
Thank you, Edwin. We'll be sure that we will tell him that the room was packed and everyone was happy. So I would like to ask two of you about how we will utilize this 43 ICE when it's available. I have a personal experience that the patient who underwent tricuspid valve replacement, EVOKE, had a severe esophageal complication. It was a very bad esophageal ulcer. Thank God she recovered completely, but once in a while we face that kind of complication. So Martha mentioned about other procedure is currently with no problem with current system, but in tricuspid intervention sometimes have difficulty. So would you try to consider adding this device?
Yeah, maybe I will.
Yeah, sure.
Yeah, so I think the problem with mini TE is the same for a standard adult TE, to be very honest, when it comes to tricuspid imaging. Tricuspid imaging get difficult because of the shadow that very nicely shown by Edwin Ho, that the catheter itself can cause shadow onto the anterior leaflets. So changing to a smaller mini will not help you at all. And that's why I think the 3D ICE may still be a complementary, in fact, will really help you to ascertain that your leaflet insertions is not questionable. Now, the thing I thought will be helpful is a pre-procedurally screening for patients with tricuspid regurgitations. I think we all know that tricuspid regurgitation patients normally have low platelet functions, liver dysfunctions, and I do have patients as part of routine adult TEE probe insertion, the patients just has a ablation, bleeding. He's bleeding from the oropharynx, and that's without any intervention. So perhaps those patients that has high risk, I think a mini TE may help actually because it's just less invasive. But an ICE will still be in my toolbox if I have a chance.
Yeah, advanced liver dysfunction disease patients has high bleeding risk and potentially esophageal varices, so on. So could be very useful. Martha, any comments?
Yeah, as said before, I mean, I think conventional TE is good for most of the cases. I mean, of course, in some cases we have difficulties. In our experience, current technology of the mini TE is not enough yet for the tricuspid. I mean, if you want to do annuloplasty, maybe yes, but for leaflet visualization is still tough, and particularly the transgastric, where we rely a lot, is not that good. because it just have no enough power. But maybe there are technological improvement. And then I think that in those patients for tricuspid interventions that you need to see the leaflets and you don't see them, I think that eyes will be a game changer. For all patients, I don't think all patients need it. I don't think we can afford the cost of all patients, but that will depend on the center and the country.
That's right, selected patients. Thank you so much for both of you for your insights. ちょっとこの今のトークまとめたいんですけど、4D アイスですね、日本にはまだ出つつあるっていうところで、まだルーチンではなかなか使えないんですけど、特に三尖弁のやはりインターベンションですね、早ければ来年ぐらいにトライクリップが承認されるであろうっていうところまで来てるので、TE でスクリーニングして術中のイメージングガイドとしてはほぼいいんですけど、やっぱり症例によっては先ほど言ってたようにそのデバイスが入るとシャドウになって一部のリーフレットが見えないんですよね。なのでそういう時に補完的に使うのは非常に有効だろうということで、非常に期待されるイメージングツールということでご紹介いただきました。So any questions, final comments from the audience? Yes, please. With your voice, loud voice.
I'm Hiroshi Ohara from Tohoku University, Tokyo, Japan. I'm an echocardiologist. Sorry, I want to English speakers, so please assist.
No problem, no problem.
I have some questions. First, conscious sedation means no intubation, is right?
Correct.
Correct.
Yes.
So,
No intubation and the patient is awake. You can talk with the patient. So,
Mild sedation.
mild.
so are there any treatment or procedure to reduce throat discomfort or reflection?
前処置みたいなことっていうことでいいですかね。Any pre-medication or anything to...
Topic pharyngeal lidocaine spray. And then we give also, I don't know what's your protocol, but we give 1-2 milligrams midazolam and then 25 to 50 micrograms of fentanyl. This is our protocol.
How's your protocol?
For me, actually, the TE is not a problem. We can do that under topical anesthesia. I mean, topical just numbing of the throat. It's the puncture that you need a little bit of sedations to calm them down. Anyway, so a lot of our patients have no issues with mini TE for sure. For bigger ones, yes, you may want to sedate them to just calm them down, but they are still conscious. A lot of my patients.
Yeah, and particularly when they are on lateral, left lateral decubitus, is better tolerated, but when they are laying on the back in the cath lab, it's worse, so they need a little bit.
なのでリドカインのスプレーとあと少量のミダゾラムだから、ドルミカムとあとフェンタニルのコンビネーションで大体いけるでしょうということで。Thank you. So thank you so much for joining this session. I think we learned a lot with the beautiful images by two of you and Edwin. So I would like to close this session. Thank you so much.